Hello, everyone. I'm Sikander Ailawadhi. I'm one of the hematologist-oncologists from the Mayo Clinic in Jacksonville, Florida, with a clinical focus on multiple myeloma and a special interest on healthcare disparities amongst the various populations, especially when it comes to disparities amongst racial and ethnic minorities. So today we will be discussing healthcare disparities in African Americans with myeloma and having some culturally sensitive conversations around this topic. Over time, the outcomes in multiple myeloma have improved tremendously. There has been data to show that as compared to, let's say, the early 2000s to the late 2000s, or even getting into beyond 2010, beyond 2015, there has been data showing how patients diagnosed in subsequent years have better outcomes, better survival. And this goes towards overall us having access to improved medications, whether it is the novel treatment agents. Some of them are not even considered novel anymore because they are so standard of care, access to stem cell transplant, etc. So when myeloma patients in successively subsequent years of diagnosis are compared with a control population or patients who were diagnosed earlier, the outcomes have improved significantly when we look at the whole population in totality. We had done some work around this when we compared outcomes of patients from different racial and ethnic backgrounds, and we noticed that actually, while there had been some data around African Americans and whites, majority of the data historically was talking about how myeloma is seen more frequently in African Americans or at a younger age in African Americans. But we did some analysis out of a large national database showing that, in fact, when we compare whites, African Americans, Asians, and Hispanics, African Americans had a better survival than whites. And in fact, Asians had the best survival amongst all racial ethnic subgroups, and Hispanics had the worst. This survival difference, in fact, became much more pronounced when only elderly patients were looked at above the age of 75. And while the difference in survival persisted, Asians had the best, then African Americans, then whites, and Hispanics had the worst. That survival probability, the outcomes, the absolute difference increased in the elderly population. When it comes to determinants of health, there are several sociocultural and economic factors that play a role. Some of these are about the patient's living situation, their family support, their disease biology and genetics. But a lot of impact comes from access to treatment, whether they are financially secure or not, what kind of a support system do they have? For example, can they even go to the visits or treatments or doctors or not? So some of these factors are considered non-modifiable. For example, the person's age, gender, certain hereditary factors, disease biology. But then others, which may be a part of this socio-cultural and economic construct of the patient, they may actually be modifiable. And we'll be talking about some of these more in depth. I do want to point out that when we talk about these factors, and I mentioned these socio-cultural, economic, and we throw in demographic, etc., these factors are quite complex and interrelated. So while a lot of work has been done on this topic, very frequently it is hard to tease out the individual impact of a factor. Still, there is a lot of data that helps point us in the right direction. There has been data to show us that the disease biology in multiple myeloma is different amongst patients from different racial ethnic backgrounds. There are studies showing that when we look at high-risk mutations, so high-risk genetic markers in the myeloma, African Americans actually have a lower incidence of the high-risk mutations. For example, the TP53 mutation which is a part of the 17p deletion or can be seen in 17p deletion, that particular mutation is seen significantly less frequently in African Americans. So if we were to think about this, actually it makes sense that the African Americans should have a better outcome in myeloma, especially if they are treated with the appropriate management. We had looked at some of the clinical factors, for example, age at the time of diagnosis. And while it has been always known that African Americans get diagnosed with myeloma at a younger age, when we look at all different races and ethnicities, in fact, Hispanics get diagnosed the youngest, then African Americans, then Asians, and typically whites are diagnosed the oldest individual age or median age. Now, we talked about disease biology and some clinical presentation like age at diagnosis, but we also looked at some of the clinical factors, the clinical presentation that is the hallmark of multiple myeloma diagnosis. For example, anemia, kidney dysfunction, need for dialysis, hypercalcemia or increased calcium, or bone fractures, because these are all myeloma-defining events. And we noticed that whether it was at the time of diagnosis or after diagnosis, within, say, about a year or so after the patient's diagnosis and management, anemia, kidney dysfunction, need for dialysis, and increased calcium are seen much more frequently in African Americans as compared to the other racial ethnic groups, while bone fractures are the one symptom or one sign that are seen much less frequently in African Americans. And that could be because of the bone density and the bone structure, which could be a part of the racial construct. But it's important to note that even irrespective of looking at the insurance status, et cetera, we did note that the myeloma defining events at the time of diagnosis or even after that, once the patient's been diagnosed and presumably on treatment, these signs and symptoms are seen much more frequently in African Americans, with the exception of fractures. We also looked at access to care. I mentioned earlier that there are so many different characteristics that play a role when it comes to how and when somebody's diagnosed and how they're treated. But out of those, access to the right kind of care has to be something extremely important. And we did an analysis, which we published now a few years ago, about in 2017, where again, looking at a large national database and looking at the utilization of drugs over 2007, 8, and 9, that was the study period we had data for, we noticed that there is a significant difference. For example, there is a significantly lower utilization of lenalidomide amongst African Americans when you compare to whites and Hispanics and Asians. We also noted that bortezomib utilization was significantly lower amongst Asians. Now, there could be several factors playing into it, but I think at least what this tells us is that there are some stark differences, and why one drug would be used less or more in a certain racial ethnic group. I think there needs to be more work done into it. And we also, for example, noticed that when it comes to Hispanics, they had the highest number of median days to the first bortezomib dose after their diagnosis. You can imagine that bortezomib is such an important treatment agent, and the median number of days for Hispanics to get to the first dose of bortezomib was 102, so more than 3 months after their diagnosis. We then subsequently did another analysis thinking, you know what, we should look at an updated database. So we looked at the utilization from 2007 to 2013 in another study. And this we published back in 2019, where it showed that while the utilization of all these novel agents for all racial groups have increased over time, it seems that the time for an African American or Hispanic to get to one of the novel therapies is significantly longer as compared to whites. So while the utilization overall is increasing for everybody, we still see that African Americans and Hispanics get to the effective agents much later, which is a stark finding. And we also looked at the fact that over time, the increase has been, for example, increased utilization of novel therapy within the first 6 months of diagnosis has been significantly lesser for Hispanics, for example. So we are noticing that as a population, there has been an increase of these drugs for everybody, but whether it is the time to the first treatment with one of the novel agents or the increased utilization over time for racial ethnic minorities, these numbers don't match up and we still have ways to go. There has been a lot of data when we talk about racial disparity in access to care for specifically stem cell transplant. And many studies have been done to point out and highlight these differences. For example, one of the studies showed that the age-adjusted odds of receiving a transplant, which basically means that the difference was not coming from age. When you control for the age, it was shown that the odds of receiving a transplant were significantly higher for whites as compared to African Americans. Similarly, another study had shown that actually Hispanics have had the smallest increase in transplant utilization over time. Another study showed that African Americans are referred for a transplant significantly later in their disease course as compared to whites. And we had also looked at one of the analysis which we published in a few years ago in 2017, again showing that Hispanics had the least stem cell transplant utilization. So not only has the increment been the smallest over years, Hispanics get stem cell transplant utilization at the lowest rate amongst all racial ethnic groups. So you can again notice that the minorities do not get access to the care in a timely fashion and sometimes not even get access to that appropriate treatment at all. There has been a lot of focus now regarding access to clinical trials, and that is because clinical trials bring newer drugs to approval and hopefully patients start getting benefit even before a drug gets officially approved. But there is data that was published now a couple of years ago showing that in myeloma, while African Americans, for example, constitute 20% of the US cancer population, they only get enrolled around 5% on the FDA registrational trials for myeloma drugs. So you can imagine, while African Americans make up 20% of all the myeloma patients, African Americans make up a little less than 5% of all the myeloma patients going on clinical trials that lead to drug approval. So keeping that in mind, that we do not even have a fully defined side effect or benefit profile for minorities when it comes to clinical trials and newer drugs that get approved. I've been also very interested in looking at the financial toxicity or financial impact of treatments on patients. And we published in 2018 out of a large national database out of the SEER Medicare database that when we look at drug-only claims or total claims for patients with myeloma, and we compare amongst patients of different races, the minorities, African Americans, actually have the highest out-of-pocket burden amongst all the races and ethnicities when it comes to either drug-only claims or total claims. And this is talking only about the Medicare population. So you can already imagine that this is bringing the patients down to a common cohort where some of the factors have already been adjusted. Another analysis that we did in 2019 and published out of the similar large database, but a larger number of years and larger number of patients, showed that there is a significantly higher healthcare cost over time amongst Hispanics as compared to whites. Again, you can feel that the same theme keeps coming out, whether it is all-cause medical bills or pharmacy or specifically myeloma-related cost. The racial ethnic minorities do pay, in literal terms, a higher price for the similar treatment. There are some other factors which we don't understand fully well. For example, we had done an analysis back about 5 years or so ago, where we showed that when looking at the access to NCI or NCCN designated comprehensive cancer centers, it seemed that African Americans only benefited from having an NCCN center in their zip code. But when it came to NCI designated centers, minorities benefited only if there were at least 2 designated NCI comprehensive cancer centers in their zip code. On the other hand, whites benefited even if there was one. So you can imagine that probably we need to have a deeper, better penetration of healthcare services when it comes to racial ethnic minorities. I had mentioned previously that when we talk about data on race and outcomes, that biology is already different. African Americans have less incidence of the high-risk disease. So what if we equalize the access to treatments? What happens then? There have been some analyses done, including one that we published back in 2018 out of the large cooperative group National Clinical Trials for Multiple Myeloma. And when we look at patients who were treated under national clinical trials, while there were differences in clinical characteristics comparing whites and African Americans and Hispanics, there were no differences in survival or even progression-free survival, which is survival prior to the disease progressing. What that tells us is that once we equate or equalize the access to care, the outcomes actually were similar. So that's encouraging. But as I mentioned, that African Americans are supposed to have a less aggressive disease. So why do they have even just similar outcomes? Why not superior? So a large analysis out of the VA database back in 2019 now showed that actually for younger African American patients who are below the age of 65, within the VA system, their survival is superior. So now within the VA system, you can also imagine is equal access to treatment options, and suddenly the outcomes of African Americans may actually be better. And that brings us the full circle, because I started the discussion by saying that we had done an analysis showing that African Americans actually had superior survival. And now we can see that once you give equal access, and considering that they have less aggressive disease biology, the outcomes must be better. And we talk about all of these things about even access to care and delayed care or later access to the right drug. These are quite loaded and difficult discussions. So we know that when looking at these disparities, that there are so many more socio-cultural, economic factors that can disproportionately affect the minorities, more so than whites. So it is extremely important that when we have these patients in our clinics, we are sensitive to the fact that there may be other factors affecting their access to care, their receipt of care, or their being able to stay compliant with the care. So I think it's extremely important to try and make the patient feel comfortable, not only about the relationship with us as their healthcare providers and their healthcare groups, but also about their own situation. So talking about the fact, and actually to start with at least acknowledging the fact that these disparities exist. Then maybe asking them, what are the factors that may be affecting their care for myeloma? Or do they have transport to come to the clinic? Do they need any help with financial assistance for medications? Can they afford the drugs? Well, I can write a prescription, but what if there is a several $1,000 out-of-pocket copayment? Unless I'm thinking about it, I won't bring it up. And if I don't bring it up, I won't try to find a solution. So it's important to make the patient feel comfortable, acknowledge the fact that there are disparities, and then not just acknowledge it, but try to address that. And it's very important to address those fears and anxieties, especially when it comes to clinical trials. Historically, mistrust and lack of education have been shown to affect minority accrual in clinical trials. And we've ourselves done a study and are actually doing it right now, where we found that African Americans have a much lower education level when it comes to clinical trials. And then we all have, luckily, resources that the healthcare system provides. For example, access to a social worker. One of the things I try to address every time is, if a patient comes from a racial ethnic minority, I will try to bring up these topics, and I will at least convince them to try and have a visit with the social worker who can introduce them to many, many more resources. A lot of times patients don't even ask what they don't know about. Once we tell them that, hey, we understand you're going through this and there are resources that can help you, it makes things better. And it's also important to kind of hold some community outreach, even in larger events, where patients can be more comfortable outside of that one-on-one intimidating feeling. When they're sitting in a group, large group, with caregivers and patients, they may be able to bring up these concerns, and hopefully we can address them better. With all of this data that we've looked at and talked about, I think it'll be very important, as I just mentioned, to understand these disparities, acknowledge them, and hopefully start making some changes so we can start to address them. I think gone are the days that we are just saying, hey, African Americans and Hispanics just don't get the right care or they get delayed care. I think that time is gone. This is our call to action to say, we know there are problems. These are the stark examples of problems. What are we now going to do about that? We are in a better situation now because there's a lot of movement to try and address this, whether it's from FDA, AACR, ASCO, American Society of Hematology. Everybody's trying to gear up. And I would say even pharmaceutical companies, patient advocacy groups, everybody's trying to gear up to address this. I think all of us need to do our own individual part as well.